All right. Well, thank you so much for coming today. I'm Carolyn Merrick. I'm program coordinator here at the center. And today we have Dr. Susan Blank here to speak with us about type 2 diabetes. Dr. Blank is originally from Tennessee and she graduated from UVA in 1995. She attended Harvard University Medical School and worked as an endocrinologist here in Charlottesville. And then in 2017, she started a company, BEATDiabetes, which is a text-based app that addresses diabetes in a personalized manner to assist patients in addressing their condition on a more macro scale. So today, Dr. Blank will share with us information about type 2 diabetes. So thank you, Dr. Blank, for coming, and I turn it over to you.
Hi, thank you very much, Carolyn, and thank everybody for joining me today. I know it's Thanksgiving week and people are busy, so I appreciate you taking some time out of your schedules to spend with me. I'm going to share my screen, hopefully.
Yep.
Okay, give me just a minute. Okay. So I'm going to talk generally and just give an overview of diabetes. And then I'm going to talk a little bit about the scope of the problem currently, both on a societal level and also on an individual level, and then end with some practical tips about diet, healthy eating, and staying physically active, hopefully to either avoid or help manage diabetes. So what is diabetes? Diabetes is a disorder of glucose, which is just a fancy name for sugar metabolism that's caused by an impairment in the body's ability to make or respond to insulin. And the official name is diabetes mellitus, and diabetes comes from the Greek for siphon or running through. And that's because in ancient times, doctors realized that patients with this condition had huge amounts of urine and also were super thirsty. So it's like the water was just pouring through them like a siphon. And then mellitus comes from the Latin for honey, which came from the realization that this urine was full of sugar. And believe it or not, the way that they would originally diagnose this was the doctors would actually taste the urine to see if it was sweet, or ones which were a little bit more squeamish would pour some out and see if it attracted bugs. And that was how they did the early diagnosis. Fortunately, we have moved on from that and now use more sophisticated manner of testing. So insulin is a hormone that's made in the pancreas, and the pancreas is an organ that sits kind of behind your stomach and intestines and the abdomen. And there are little cells called beta cells, which sit in these groups of cells called pancreatic islets, which are responsible for producing hormones that are kind of scattered throughout the pancreas. And in somebody who doesn't have diabetes, what normally happens is you eat a meal and some glucose or sugar is absorbed from the stomach, and that sends a signal to the pancreas to release insulin. And that insulin in turn allows the glucose to be stored in the liver or used by the muscles or other organs, and keeps the blood sugar level in the blood pretty consistent. And the way on the cellular level that the insulin works is it works almost like a key to unlock the insulin receptor, which then activates a glucose channel, which allows the glucose or sugar to go into the cell so it can be stored or used. So in normal physiology here, again, we'll just kind of review the insulin, which are these little purple diamonds, binds to the insulin receptor, which then activates the channel that allows the sugar to come into the cell. In type 1 diabetes, the problem is the pancreas basically stops making insulin altogether. So you can see here, there are no little purple diamonds, there's no insulin, so the sugar can't enter the cell. In type 2 diabetes, the problem's a little bit different. The pancreas, at least early in the disease, still is making insulin. And in fact, as you can see here, a lot of times it actually makes more insulin than a person without diabetes would make. But the problem is with the insulin signaling, so that insulin isn't as effective. And so even though there's insulin around, the sugar can't get into the cell, and that leads to high levels in the blood. So I'm going to spend most of the talk talking about type 2 diabetes, but I thought it would be helpful just to review for a minute the two different kinds to make sure that everybody's on the same page. Type 1 diabetes is due to a lack of insulin, and that is generally due to autoimmune destruction of those pancreatic beta cells that we talked about a few minutes ago. And the typical patient with type 1 diabetes is young, which is why this used to be called juvenile diabetes, but that's not always the case. It can present at any age, but traditionally we think of it happening in younger patients. People also tend to be thin, although again, that's not universally true. And people usually present how I described early in the talk with increased thirst, increased urination. People lose weight even though they're hungry and eating a lot. And then if it's not caught early enough, it can degenerate into a life-threatening condition called diabetic ketoacidosis, where people get severely high blood sugars, they get dehydrated, they have nausea and vomiting and abdominal pain, and can eventually affect consciousness and is a medical emergency. And so people with type 1 diabetes, the only real treatment currently is insulin, and they are dependent on it to stay healthy. And so another kind of older name for type 1 diabetes is insulin-dependent diabetes, which you may have heard before. So type 2 diabetes is a little bit different. The problem, is with impaired insulin action, and that's due to insulin resistance. The typical patient is usually in middle age, although especially with the obesity epidemic, we're seeing people present at younger and younger ages, and even sometimes in children now. And the typical patient is generally overweight, although this is not universally true, and we can see it in thin people, especially if they have a family history of type 2 diabetes. And most people with type 2 diabetes don't have much in the way of symptoms. It's usually picked up just on routine screening in the doctor's office. And they're fortunate in that there are a whole lot more treatments for type 2 diabetes. Some people can be treated just with diet and exercise alone. There are a lot of oral medications that can be used. There are fairly new medicines that are injections, but they're not insulin. And then some people with type 2 diabetes do need insulin, although fortunately they don't get as sick if they miss a dose as somebody with type 1 diabetes would. So moving on, just to discuss kind of the scope of the current problem. This is a chart that looks at the prevalence of diabetes, both type 1 and type 2, over the past 60 years. So from 1958, I'm having a hard time with my pointer, from 1958 up to around 2015. And you can see there's really been a dramatic increase in both the percentage of people with diabetes, which is in yellow, and the number of people with diabetes, which is in blue. And that's especially seen over the past 25 years or so, where it's really kind of taken off and gone up at a really rapid clip. So the most recent numbers we have are from 2018 and suggest that there are close to 27 million people with diagnosed diabetes and another 7.3 million people who probably have diabetes, but it hasn't been diagnosed yet. So the estimate is that there are 34 million people in total with diabetes. And the vast majority of those people are type 2 diabetics, around 32.5 million, with about 1.6 million having type 1 diabetes. And the majority of this rapid increase is also due to type 2 diabetes, although we are seeing some increase in the prevalence of type 1 diabetes over time, which nobody quite understands yet. And the real problem is that 32.5 million is really just the tip of the iceberg. There are another 88 million people, adults in America, that are estimated to have prediabetes. That's around 1 in 3 American adults who have prediabetes. And the majority of people with prediabetes will go on to develop type 2 diabetes unless they are able to make pretty significant changes in diet and exercise patterns and lose weight. If they do that, they can avoid it, but without intervention, the majority of those people will go on to develop type 2 diabetes. So we're really kind of looking at a tsunami of cases unless we make some changes. And all of that comes at a large cost, both in terms of health and finances. So on the health side, diabetes is the leading cause of blindness and non-traumatic lower limb amputation and kidney failure in the United States. And it's associated with higher rates of heart attack, stroke, and cardiovascular death, around 1.5 to 1.8 times that of somebody without diabetes. And it's the 7th leading cause of death in the United States. And it also comes at a large financial cost. So the estimated cost in 2017 to the United States economy was $327 billion, which is around 1 in 7 US healthcare dollars, which is now being spent on type 2 diabetes or its complications. And you can see that that number is rising pretty steadily and at a fairly alarming rate. A lot of that is due to the increase in prevalence and just the number of people who have diabetes. And part of it's due to some of the new treatments, which are wonderful, but also have pretty hefty high price tags in some cases. So what are the risk factors for type 2 diabetes? They kind of fall into two categories. There are ones that people really don't have any control over, and then there are ones that are within people's control. So on the non-controllable side, there's genetics, which is family history. There's age, being male, belonging to a high-risk race or ethnic group. And then there are certain health conditions which are associated with a higher risk of diabetes, including high blood pressure, and for women, a history of diabetes while they were pregnant, or something called polycystic ovary syndrome. On the controllable side, it has to do with weight and also how active people are. So those are the things that we can control that can decrease our risk of developing type 2 diabetes. So looking at some of these risk factors, this looks at the prevalence of diabetes by age group. And you can see that young adults have a fairly low risk, only about 4% will have type 2 diabetes. By middle age, it increases to around 17%. And if you look at the group of people who are 65 and above, over a quarter of people will have type 2 diabetes. So that we can't control, but certainly goes way up as we get older. There's also a higher risk of type 2 diabetes in men. And then people who are Black or Asian or Hispanic also have higher risks of type 2 diabetes than people who are white. Part of that is probably genetic. Part of it is probably socioeconomic factors that may be playing into some of those disparities. And then this looks at weight. So it's a diabetes risk by the body mass index. And body mass index, if you're not familiar with it, is a measure that takes into account both your weight and your height. So it's basically your weight divided by your height squared. And if you're interested in figuring out what yours is, there are a lot of online calculators that you can do where you can just type in your height and weight, and it'll tell you what your body mass index is. But people with a body mass index under 18.5 are considered underweight. People between 18.5 and 25 are considered normal weight. And then between 25 and 30 is overweight, and over 30 is considered obese. And you can see that people with normal weight have fairly low risk of diabetes, although it's not zero. And then it kind of increases once you move into the overweight category, and then increases more dramatically as those body mass indexes go up till it gets to a pretty high percentage for people who have very high BMIs. And you can see this play out on a societal level. This is data from the CDC, maps looking at both the prevalence of obesity and diabetes over time. So this top row looks at the prevalence of obesity. So on one side of the scale are these kind of light brown color, which is less than 14%. And on this side of the scale, it's the dark red, which is 26%. You can see back in 1994, there were a decent number of states who were on this very lower end, nobody who had greater than 26%. And then over that 15-year time period that this looks at, by 2009, the majority of states, or at least half of them, have over 26% of their population being obese. And that's mirrored, although with a little bit of a delay, in the diabetes data. So again, the lighter color is less than 4.5% of the population having diabetes. The red is greater than 9%. And you start off with a lot of states on the very lower end of the range. That everybody kind of shows up in the medium category. By 2009, we're starting to see a number of states, especially those in the Southeast, that have over 9% of their population with diabetes. And then this is the most recent data. This is from 2015. And you can see here that the majority of the states have over 26% of people having obesity. And we're starting to approach that with diabetes as well. And I'm sure when the newer data come out, which should be relatively soon, unfortunately, these will look even worse. So I thought just quickly we would do together a pre-diabetes risk test. And this is just a really simple test that you can kind of do along with me, and you can just count on your fingers points as I ask the questions. So, so the first question is, are you a man? So if you're a man, put up one finger. Do you have a family history of type 2 diabetes? So that would be a history in either a parent or a sibling, counts for this. Then you can put up another finger for another point. Do you have high blood pressure? And are you physically inactive? And then the next question is, are you overweight? So that can range from 1 if you think that you're somewhat overweight, 2 fingers if you're moderately overweight, 3 if you're very overweight. And then this next question is about age. So if you're over 40, you get 1 point. If you're over 50, you get 2 points. And if you're over 60, you get 3 points. So count up your fingers, see how many you have. And if your score is 5 or above, you have a fairly high risk of having prediabetes, and you should probably talk to your doctor and make sure that you're getting evaluated for it if they haven't already done so. And the way that we usually check for this is with a blood test now, not tasting urine, which is a good thing. And there are 2 main blood tests that we use. And a lot of you may have already had these as part of just your regular annual physical. So the main ones that we use are in the first 2 columns. There's a test called the hemoglobin A1C, and that looks at the average blood sugar over a 2 to 3 month period. And we want that ideally to be around 5. It's considered pre-diabetes if you're between 5.7 and 6.4, and then you're considered to have diabetes if it's 6.5 or above. And we usually, if somebody has diabetes, this is what we use to follow treatment, and we like for it to be under 7 if somebody is being treated for diabetes. For the most part. Sometimes we also use fasting plasma glucose. So when your doctor has you go in for a fasting test, a lot of times this, along with cholesterol, is one of the things that they want to look at. And that is considered normal if it's under 100. If it's between 100 and 125, it falls in this pre-diabetes category. And if it's 126 or above, then it's considered diabetes. Sometimes we do this oral glucose tolerance test, but it's a little bit more involved. It involves going in and drinking a really sweet, sugary drink and then having your blood sugar test later. So usually we primarily stick with the first 2. And the reason why the testing is so important is that most people who have diabetes are asymptomatic, and the only way that they're picked up is with laboratory testing. And it's thought that many people with diabetes have had it for a number of years, and some even have complications by the time they get diagnosed because they really don't feel bad. And people usually continue to feel well after they're diagnosed unless their blood sugars are really horribly out of control. And if they're very high, then people can start to get symptoms like I described with type 1 diabetes, where they feel really thirsty and are peeing a lot, have blurry vision, things like that. But that's pretty unusual. So the main symptoms that people get from diabetes are usually not from the high blood sugars themselves, but from complications from the diabetes. So diabetes has a whole host of complications which fall into 2 main categories. They're microvascular complications, which have to do with damage to the small blood vessels in the body. And then there are macrovascular complications, and those are ones that have to do with the larger blood vessels. So on the microvascular end, diabetes can cause damage to the eyes, especially the retina, which is one of the reasons why it can lead to blindness. And it's very important for people with diabetes to get regular eye exams so that can also be caught early and treated if necessary. It leads to kidney damage, which is one of the reasons why it's one of the main reasons why people end up on dialysis. And then it can also cause neuropathy, which is damage to the little nerves, primarily affects the feet in most people, and it can cause numbness and tingling and some pain that can be really difficult to treat. And then on the macrovascular side, it can cause damage to some of the larger vessels, and this can translate into a higher risk for strokes, a higher risk for heart attacks. And in the extremities, it can cause some pain because of lack of blood flow, but also impairs healing. And the combination of the damage to the nerves and the damage to the blood vessels can lead to non-healing ulcers and gangrene, which is why some people with diabetes unfortunately end up having amputations at some point in their treatment. And the combination of damage to the nerves and the small blood vessels can also lead to erectile dysfunction in some men. So we know that the risk of complications is tied to how well the blood sugars are controlled. So this is data from a study called the Diabetes Control and Complication Trial, which is pretty famous in the diabetes world. And it looks at the risk of various complications by the hemoglobin A1C level. So, the hemoglobin A1C, if you remember, looks at the average blood sugar over time, and we really like it to be under 7 ideally. And part of that is because of the study that showed that people who have it under 7, who keep it in a fairly normal range, have very low risk of complications. But as that number creeps up, the risk of all these complications, the retinopathy, which is eye damage, the nephropathy, which is damage to the kidneys, and the neuropathy, all go up a lot. So it's important, even though people don't usually feel that bad because of the high blood sugars, that we really treat and get the blood sugars down to minimize the risk of these complications. So the treatment for type 2 diabetes focuses on diet, exercise, and weight loss as first-line therapy, and these are things that we recommend to everybody. And for some people, this is enough and can even reverse the diabetes and get rid of it entirely. But if that's not enough, then we have a whole host of pharmacologic options now. There are a bunch of oral medications. Metformin is one of the ones that's most commonly used early on, but there are a lot of different other ones that we have that we can use if needed. There are also non-insulin injections. So these are relatively new. These are GLP-1 agonists. You may have heard of Victoza or Byetta. They're on TV a lot in commercials, and these can be really helpful and also have been shown to help people lose weight and lower the risk of some of the cardiovascular complications. And then some people do end up needing insulin. For people who, for weight seems to be a major driver of why they have diabetes and other health problems. Sometimes we consider bariatric surgery, which would be things like gastric bypass, which can be very helpful in reversing diabetes, but obviously it's a big commitment to do that. So now I'm going to just talk about some practical tips for healthy eating and active living. This is one of my favorite quotes about just food advice in general. It's from Michael Pollan, who is a food writer. He wrote Omnivore's Dilemma and also a really helpful book called Food Rules. And his advice is to eat food, not too much, and mostly plants. And I think if you really follow this, that's most of what you really need to know. So I'm going to kind of break it down and talk about it and give some specific tips. So as far as eat food, what he really means is he wants us to eat whole foods, lots of produce, lean meats, things like that, and not what he calls food-like substances, which are packaged and highly processed foods, which have been associated with a higher risk of a lot of health problems, including diabetes. So this is another quote for him. If it came from a plant, eat it. And if it was made in a plant, don't eat it. So when you're shopping, you just want to try to minimize your intake of foods that come out of a box or package, things that your great-grandparents wouldn't recognize as even being food, things that have ingredients that you can't pronounce, or things that don't go bad. Those are kind of things that you should at least think twice about having. And one of the easy ways to do this is focus most of your shopping on the outer aisles of the grocery stores. Most grocery stores are set up so the produce and the meat and dairy are on the outsides, and a lot of the packaged foods are on the inside. There's certainly some things like beans that are great and usually found on the inside of the grocery store. So these are not hard and fast rules, but in general, you want to kind of eat things in as close to their natural state as you can. And then not too much really talks about portion size. And I think part of the problem here is that the portions that we get in restaurants have changed so dramatically over time that it's really distorted our view of what is a normal portion, and it can be hard to kind of readjust your expectations. So the average restaurant meal today is more than 4 times the size of an average restaurant meal in the 1950s. And this has even kind of gotten into our homes and the size of dinner plates. So the dinner plates that were sold in the 1960s were around 8.5 inches in diameter. And the ones that are sold primarily now are 12 inches in diameter. And they can hold about twice as many calories. So in our brains, we usually just kind of pile it on to fill up the plate. We don't think that much about exactly how much we're putting on. And so that's led to people just eating bigger portions in general. So there are a couple ways that are pretty easy that you can use to combat this. One thing is just to switch the size of the plates that you use. So if you switch from a big dinner size plate to what is a salad plate, which was probably the normal size plate in the 1960s, there's been research that's shown that if people switch to smaller plates, they will eat around 20% less without even realizing it. They just serve and eat less without noticing or missing those extra calories. And I know most of us aren't spending much time at restaurants these days, but a lot of restaurants, especially the bigger chains, give really super big portions. So there are a couple ways around this. One thing is just to order a half portion if it's available, and some chains do have that. You can split a meal with a friend, or another way is just to ask for half of the meal to be boxed up before it even reaches your table. And that way you eat a more regular sized portion, and then you have another meal ready for later in the week. And mainly plants. I think the simple rule, which is what I follow and try to get my kids to follow, is to try to get half of your plate to be filled with fruits and vegetables. And we're talking non-starchy vegetables, so unfortunately potatoes don't count for that half of your plate. And there are a couple corollaries to this. One, which I think is very timely given that we've got Thanksgiving coming up, is to try to follow the rule if you go back for seconds. And also when you're shopping, to be conscious of this and try to fill half of your grocery cart with produce, because if you don't have it in the house to make, then it's hard to fill half of your cart with fruits and vegetables. And frozen fruit and vegetables are great. They're healthy. And so that's an easy way to do it. I know a lot of people struggle in the winter, especially with getting fresh fruits and vegetables, and they can be more expensive. So frozen fruits and vegetables are fine. Canned ones are fine. You just want to watch the sodium content. So try to get low sodium ones, or rinse them off after using those. And the reason why plants are so important is that they're a great source of fiber, and fiber, sorry, I've got a very twitchy PowerPoint today. They increase your sense of fullness, so it cuts down on how much you eat, and it also delays absorption of sugar, so people don't get spikes in their blood sugars. And it's associated with a decreased risk of type 2 diabetes and heart disease, also good for bowel health and overall health. And then another kind of general tip is to set yourself up for success by making the healthy choice the easy choice. Willpower is overrated. It's really hard to just go on willpower. So the more that you can set up your environment so that the healthy choice is the easy one, the better you are. I think the easiest way to do this is just to really focus on making good choices at the grocery store. My downfall is ice cream. And if I buy ice cream at the store, I will eat it within a few days. I just, I can pass it up a certain number of times, but eventually I'm going to eat it. But if I don't have it in the house, I probably am not going to crave it enough that I'm actually going to go out and get it. So if you just make sure that you have healthy food in the house to be your go-to, then that's probably the most important thing in setting yourself up for success. Packing your lunch can be really helpful, because you're more likely to make good decisions when you're at home the night before than if you're stressed and in a hurry and eating out. If you are at a restaurant and you just decline the bread basket or chips and salsa, once it's on your table, you're almost certainly going to eat it. And just really making healthy snacks obvious So putting a fruit bowl out on the counter, cutting up vegetables, putting them at eye level and in clear containers in your refrigerator, things like that. So it's easy to grab a healthy snack that's not going to take you extra steps that are going to keep you from following through and eating healthy. And as far as exercise, the recommendation from the American Heart Association is for people to try to get at least 150 minutes a week of exercise, which breaks down to around 30 minutes 5 times a week. But if you can't do 30 minutes at a time for whatever reason, you can get almost as much benefit by breaking that into small chunks. So if you can't do the 30 minutes, if you do a small burst of 10 minutes, 3 times a day, that can be helpful. A lot of people find it helpful to treat exercise like an appointment and really make it a priority, put it in your schedule and just make it something that you do automatically. Exercising with friends can make it more fun, also add some accountability, which makes you more likely to follow through. You can try bundling it with something that you like to do. So if you make a deal with yourself that you're only going to watch a favorite TV show or listen to an audiobook that really has you hooked while you're exercising, you can turn exercise from something that you kind of think of as a chore to something that you're looking forward to because you want to hear the next installment and the story that you're listening to. And then another tip is just as much as you possible, try to build exercise into your daily life. So doing things like taking the stairs instead of the elevator, parking a little bit farther away from the store when you walk in, all of that can add up to a lot of extra steps and a lot of exercise over the course of your day. So I'm just going to spend a couple minutes talking about the diabetes program that I'm running now in case anyone is interested or you know people who might be able to benefit. So it's a text message-based program that's designed to support and motivate people with type 2 diabetes and prediabetes to help them make healthy choices between doctor's visits. And the problem that we're trying to solve is something called the 5,000-hour problem, which is that people only spend around 2 to 3 hours at most a year in diabetes-related healthcare encounters. But their outcomes, as you probably realize after listening to this talk, are really dependent on what people do during the other 5,000 hours. So making healthy food choices, being physically active. For people with type 2 diabetes, we may be asking them to check their blood sugars or take medications. And all of that's a lot of work, and it's not being done in a vacuum. It's being done surrounded by a bunch of distractions. And also we're constantly surrounded by temptations in the forms of unhealthy food and sedentary leisure activities like TV and computers. And that can make it hard for people to stay on track. So the program consists of a few components. We send people tips, which are semi-customized advice on diet and exercise and diabetes prevention or self-care that are delivered a few times a week that are designed to be really simple and actionable. If people want to, they can set up optional customized reminders to check blood sugars, to take medications, to exercise. And everyone knows that good health is the ultimate reward, but sometimes it can be really hard to focus on chronic conditions like diabetes when there are more pressing issues. So to add a little bit of a short-term incentive and to help motivate people, if people are able to improve their A1C test that we talked about earlier, then they can earn entries into a $1,000 drawing that's held a few times a year. And the program is free for people in Charlottesville or the surrounding counties with prediabetes or type 2 diabetes. And the only thing that people need to participate is just a mobile phone that can accept text messages. So if anyone is interested in learning more or wants to sign up, then they can go to our website, which is www.beat2diabetes.com. So just in conclusion, diabetes is a disorder of glucose regulation that's due to either a lack of insulin in type 1 diabetes or impaired insulin action in type 2 diabetes. And type 2 diabetes is a large and growing public health problem and can have serious complications if the blood sugars aren't well controlled. And there are some simple, concrete ways to live a healthier lifestyle and reduce and manage your risk of type 2 diabetes. So that is all I have. I will stop sharing my screen and I'm happy to answer any questions that people have either via chat or if people want to unmute themselves, I guess, if that's okay, Carolyn.
Absolutely, yeah. Anybody have any questions or comments? That was a great presentation. Thank you. It's a lot of information. I learned a ton.
Thank you.
or I have a question.
Okay.
So, you showed those maps that had the disproportionate changes in type 2 diabetes over time. And you mentioned several factors, but if you could pin it to one particular factor, is there any one that you would say is the biggest culprit in your mind?
As far as all the risk factors are kind of within the obesity category.
Uh, well, let me back up a little bit and say I've heard things like, well, some people, because they're eating processed foods, aren't getting all the nutrition, for example. So they're constantly hungry. So it
Right.
creates, all right. So
Yeah.
yeah.
Yeah. I think part of it, I think the processed food is a big component. And if you look more broadly, not just at the United States, but globally, when you see diets move from traditional diets to more processed diets, or you see immigrants come to the United States or to Western countries and adopt a more Western processed diet, that's a lot of it. I think portion control is certainly a lot of it. And I think, it's pretty revealing if you look at kind of how that's gone over time. And then I think kind of the rise of TV and computers and just spending so much of our life and leisure life sitting down in front of a screen has really contributed to. But the food seems to be a bigger component than exercise overall. And I think, the rise of processed food, I think, is a lot to do with it. People, and part of it is also fueled by kind of economic incentives. It's people say that calories are cheap, but nutrition is expensive. And so a lot of those packaged foods are more readily accessible, they're cheaper, they're shelf stable. And so I think a lot of people rely on them for a variety of reasons, including convenience and cost. And so it's a huge part of a lot of people's diets.
Great, thank you. Somebody asked, could you ask about treatment for erectile dysfunction? So what if someone has that as a result of type 2 diabetes? What do
Yeah,
you?
so usually the treatment, so it is a much higher risk for men with type 2 diabetes because of nerve damage and then blood vessel damage. So I think that, the first thing would be to try to keep the diabetes as well controlled as possible to minimize any ongoing damage. The treatments are really the same as they would be otherwise. So medications like Viagra are kind of the mainstay of treatment, although there are other surgical options and medical options too.
But none of the prescribed things for diabetes in general are targeted for ED.
None of them are specifically for erectile dysfunction. So, but generally, controlling the diabetes and controlling the blood sugars helps. And some of the damage, I will say, from to the nerves especially, is somewhat reversible. So sometimes, if you're able to improve blood sugars, even if they've been uncontrolled in the past, some of the neuropathy that we see both with ED and people's feet especially can improve with blood sugar control. But they're not specifically different for ED for people with diabetes.
Great, thank you. If anybody has any questions, I see there's a question in the chat, but I'm not really sure what it is. So if you want to unmute yourself, you're more than welcome to do that if it's easier for you than writing in the chat. It's interesting to hear too that prediabetes or diabetes can be reversed if in some people. I know that happens. Yeah, that's exciting.
Especially the prediabetes, and if people are picked up early, there's a lot that people can do to get it under control if it's caught early enough. Yes, I highly suggest Michael Pollan. I think the Omnivore's Dilemma is a very interesting book. But if you're looking for more kind of diet advice, he's got a book called Food Rules, which has it's kind of short snippets. I can't remember how many. It's probably got 150 kind of rules, and he's a great writer, so they're all kind of pithy. So it'll be like, don't eat anything that your great grandparents wouldn't recognize as food, and things like that are easy to remember, but all really good advice. So I would recommend reading him if you're interested. And yeah, somebody wrote stand up. That's true. A lot, there's been research that's shown not just exercise, but the amount of time that we spend sitting constantly also can lead to insulin resistance and a higher rate of diabetes. So getting up and moving around regularly in the course of your day, every half hour or so, getting up and walking a few hundred steps or walking up some stairs, doing some calf raises, something like that, anything like that can help.
And another question I have, if you don't mind, is what was the impetus for you to develop this app or this text-based messaging?
Yeah, so I saw a lot of people with type 2 diabetes in my practice, and I realized that it was really hard for people to stay on track between visits. So I would see them and we would have a great discussion, and they would know what they needed to do. And we would feel like everything was on the right track, and they would usually do well for a while after they left the office. But then everybody has really busy, kind of chaotic lives, and usually over time things would kind of degenerate as other things became kind of more pressing. And so a lot of times I would see them 3 months later and they would be back in the same situation. And then I would see them 3 months later and be back in the situation. And then I started spending time helping people program reminders into their phones if they were having a hard time remembering. And then I got interested in behavioral economics and kind of how do you get people to make changes in lifestyle. And it seemed like providing people with more engagement in between visits and with reminders and help kind of in the moments when they were actually making the decisions that were going to affect their health might be useful for people. And we've done the people who've done the program so far, a lot of people have found it successful and have really improved their blood sugar results and enjoyed it. So it's not for everybody, but there are definitely people who find that more consistent encouragement and advice helpful.
That's great.
But things like if people are watching TV, just standing up during the commercials and walking around or doing a little exercise during those commercials, things like that, so that you're really kind of consistently moving more over the course of your day. All that adds up. So it doesn't all have to be kind of getting on a treadmill and running for 30 minutes or things like that. Just a lot of kind of day, exercise that you can kind of build in your day and extra steps that you built in. Sometimes those wasted motions are actually helping you if you're moving around.
If you don't mind, I have one last question or comment. I noticed that you mentioned fruit and vegetables. So, oftentimes with diabetes, you hear, that people should avoid fruit. But I wondered if you could speak to that, because it is a whole food, right?
Right. Yeah. I think fruits are okay in moderation. You have to be a little careful, or people with diabetes especially. I think people with prediabetes don't need to worry about it quite as much. I think there are no fruits that I would say are off limits if you have prediabetes. And even if you have type 2 diabetes, you just need to be a little bit more careful with the ones that are super sweet and juicy. There's something called Glycemic Index, which looks at kind of how likely things are to raise your blood sugars. So the ones that are a little bit less sweet and have more fiber are better. So things like berries and cherries tend to have less of a chance of raising your blood sugar. Things like grapes, maybe a little bit higher chance of raising your blood sugar. I think the one key I will say with fruit especially is that it's much better to eat a fruit instead of to drink a fruit. And that really has to do with the fiber. So if you have juice, you've taken out most of the fiber. And you can drink it really fast and your body just doesn't really take it in the same way. So you can drink a glass of orange juice really fast without thinking about it, and you would never eat the 4 or 5 oranges that went into making that orange juice. And because you've taken out the fiber, it doesn't make you full, and it can really make your blood sugar go way up. So I think the whole fruit is fine. You have to be really careful about juices.
Well, and again, as Dr. Blank said, if you have any questions, you can just email me and I will be happy to forward them to you. And as well, the Beat type 2 diabetes, if you didn't catch that address, you can send me an email and I will send you the link to that as well.